Hi everyone, welcome to the video lecture on Preventive Dentistry Part 4. I am Dr. Fawaz Siddiqui from Department of Pediatric Dentistry, and today we are going to look at the topical fluorides used in prevention of caries. The intended learning outcome is that by the end of this lecture you should be able to discuss role of topical fluorides in prevention of dental caries. Okay, so with that background, let's start with the classification of use of fluoride in prevention of caries. So we have systemic fluoride and we have topical fluoride in the prevention of caries, and this table basically tells us the differences between the two kinds of fluoride. So you must understand that when you talk about systemic fluoride, we are talking about systemic acquisition of fluoride by the tooth. That means the fluoride reaches the tooth through the blood, through the body fluids, and it is there during the pre-eruptive stage of enamel development. The fluoride uptake by systemic fluoride is maximum when the tooth is in pre-eruptive maturation stage of enamel formation, and that is where the maximum fluoride gets deposited into the enamel as fluorapatite crystals are formed instead of hydroxyapatite. So basically, if you are using systemic fluoride, you can use it only before the enamel formation is complete. So the window period is during the enamel formation or during the tooth development. And once the tooth has finished development, is developed completely, it is erupted in the mouth, then systemic fluoride is of no use. And for this systemic fluoride application, we need to use very low concentration of fluoride, because the fluoride not only gets deposited in the tooth, but it also has affinity for other calcified tissues of the body like bone, and therefore you find during high toxicity of systemic fluoride you have dental fluorosis and skeletal fluorosis. And the use of systemic fluoride is actually twofold. For example, if your water is fluoridated, so when the child drinks the water, the fluoride comes in contact with the tooth when the water is in the mouth. Then when the water is ingested, okay, the fluoride is available through the body fluids, through the plasma to the developing tooth bud. And number three, the fluoride is also excreted into the saliva. Okay, so the fluoride reaches the oral cavity through the medium of saliva. So it has a multi-pronged approach to the tooth when we talk about systemic fluoride. And basically what systemic fluoride does is it changes the morphology of pits and fissures. Studies have found the pits and fissures are shallower in tooth which are fluoridated using systemic route. So as compared to the topical fluoride, so the question is that if you miss the window period of tooth development, can we still protect the tooth using fluoride? And that is where the topical fluoride came into the picture. So when we apply topical fluoride, the fluoride is acquired by the tooth surface by local application, and it is incorporated into the tooth post eruptively. That means only after tooth has erupted, the topical fluoride can be beneficial. And maximum uptake of fluoride is during the post eruptive maturation stage of enamel. That means when the tooth erupts newly in the oral cavity, the maturation phase of its matrix is still incomplete and it continues post eruptively. And if at this moment topical fluoride is applied, the fluoride uptake by this immature enamel is higher. And of course topical fluoride is indicated only when the enamel formation is complete, and for this purpose we require a higher concentration of fluoride when we are doing topical fluoride application. Because we are applying topical fluoride, the whole situation is very well controlled, so you can control the amount of fluoride that you're applying on the tooth. So there are low risk of systemic ingestion and therefore low risk of fluorosis. The only advantage we have here is the topical fluoride. We do not have any systemic fluoride advantage. So as long as the topical fluoride agent remains in the mouth, it is useful. And what topical fluoride does is basically it changes the structure of the superficial layer of the enamel only. And studies have found that the superficial layer of the enamel, that is up to 5 microns, has got maximum fluoride in it. Okay, and after that the level of fluoride concentration decreases as you go deeper into the tooth. So the superficial layer of the enamel is very important. So it is very important for us to understand these differences, and from this table you will understand why we need to use topical fluoride and when we can use systemic fluoride. So when we talk about topical fluoride, let us understand the best time to apply topical fluoride. You must remember that whenever the enamel is porous, okay, and hypermineralized, the fluoride uptake is faster and higher. So when we talk about porous enamel, we can relate to the post-eruptive maturation stage where the newly erupted tooth has got porous enamel, or when we talk about hypermineralized tooth structure, we can also think about non-cavitated carious lesions. So non-cavitated carious lesion is when the tooth has lost its calcium and phosphate, so it's lost its minerals, right? And if at that time, in that particular clinical condition, if you apply fluoride, the uptake is much more higher, because not only the tooth is hypomineralized, but tooth is also more porous because of loss of calcium. So these two are the best time to apply topical fluoride. Also, the fluoride porosity of the enamel can be increased by etching the enamel by a phosphoric acid, or conditioning the enamel before you apply topical fluoride, or if you can dehydrate the enamel, the fluoride uptake is higher and faster. So the best time to apply topical fluoride is when the tooth, as soon as the tooth erupts, or when you see a white spot lesion or a non-cavitated carious lesion or incipient carious lesion. That is the best time you must start applying fluoride. And if you want to increase the uptake of fluoride, maybe you want to condition the enamel by using a weak phosphoric acid to etch the enamel to increase its porosity, so the topical fluoride is higher. We will discuss this later, how the manufacturing companies have used this concept of etched enamel to make a unique product. All right, so we will quickly recap the mechanism of action of fluorides. So we remember that when fluoride reacts with the hydroxyapatite crystals, it converts those hydroxyapatite crystals to fluorapatite crystals, and those fluorapatite crystals are a much more stable crystals and larger crystals. So when we talk about stable crystals, that means their enamel solubility by an acid attack is less. So if the acid is if the enamel is comes in contact with the acid, that is the hydrogen ions, the calcium ions are less likely to be lost. So that is what is meant by decreased enamel solubility. So what happens if you apply topical fluoride on the tooth? In a newly erupted tooth, you have this decreased enamel solubility by formation of fluorapatite. So as I discussed in the last slide, the post eruption maturation is still going on. So if you apply topical fluoride on a newly erupted tooth, you will have the surface layer which consists of fluorapatite crystals. And what fluorapatite crystal does is that it fills up any areas of missing hydroxyl ions in the hydroxyapatite, and thereby it causes the crystals to become larger, and these crystals are more stable. So when we say the crystals are more stable, is that the critical pH of fluorapatite is 4.5 as compared to the critical pH of hydroxyapatite, which is 5.5. So it is able to withstand one drop in pH level as compared to hydroxyapatite. This is what is meant by a stable crystal. So on a newly erupted tooth, fluorapatite, and when the tooth is challenged by an acid attack, if you apply topical fluoride, it forms a shell of fluorapatite crystal on the surface of dissolving hydroxyapatite crystal, and thereby reducing the enamel solubility, and therefore the caries progress is arrested, and the tooth tries to remineralize the parts which have become demineralized. And the last effect of topical fluoride is the antibacterial effect of the fluoride itself. So this fluoride, when you do topical fluoride, it gets deposited into the plaque, and in the plaque, the plaque itself acts as a reservoir for ionized fluoride, which is released when the pH falls. Whenever there is a fall in the pH, the fluoride which is there in the plaque is released to immediately form fluorapatite by forming this shells of fluorapatite crystal on the dissolving surfaces of hydroxyapatite. So Fluoride itself interferes with the bacterial enzymes like enolase, phosphatase, and the cation transportation, and thereby disrupts the bacterial metabolism, and therefore it has got a bacteriostatic effect also. So what this is all that happens when you do topical fluoride application on a tooth. So to summarize, what happens is if the fluoride gets incorporated into the enamel crystals, it improves the enamel crystallinity, right? So the crystals are larger and more stable, and this causes decreased solubility during an acid attack. And the fluoride also catalyzes the stable apatite crystals by making it more stronger, more stable. And if the fluoride is present in the plaque, it promotes remineralization, and it increases the less soluble phase of enamel solubility. So enamel solubility is a continuous process. Enamel solubility is the demineralization process, so it keeps going on. But if the fluoride is there in the plaque, it lessens the soluble phase of enamel solubility, and thereby protects the tooth against demineralization. And the last is the decreases fluoride formation by interfering with bacterial metabolism, and thereby acting as a bacteriostatic agent. So this is a summary of what topical fluoride can do when applied to the tooth structure. So to have a successful fluoride treatment, we have to have a high concentration of fluoride. So any product that we use must have a high concentration of fluoride. We have to increase the frequency of application, so we have to apply more frequently. We have to increase the time of exposure, so each time when you apply, the enamel is in contact with the fluoride has to be high. If we can do a pre-treatment of the enamel surface like etching or conditioning, the fluoride uptake is higher and deeper. And we can also use complexing agent with the fluoride. We cannot apply a pure fluoride to the tooth, so if we can complex it with some metals like aluminum or stannous, it shows that the fluoride uptake is much better. And if we have a presence of plaque, the fluoride reservoir is formed. So when I talk about the plaque, it is not the pathological plaque, it is the plaque which forms after the tooth is cleaned. So you have this glycoprotein deposition on it, and the biofilm forms, which is non-pathogenic, and that is the plaque that we require as a fluoride reservoir. And of course, if we can take the caries risk assessment of the patient under consideration, the number of times the fluoride application can be individualized for the treatment of the patient, and we can have more frequent application as a caries risk assessment says. So high caries risk patient require more frequent applications, every 3 months application, every 4 months application. So this helps us for successfully handling the preventive phase or the maintenance phase in a patient who is having caries. So the topical fluoride itself can be divided into two categories: the professionally applied topical fluoride and the self-applied topical fluoride. So this table basically tells you the differences between the two. So the professionally applied topical fluoride normally have higher concentration of fluoride, more than 1000 parts per million, basically because there's less chances of ingestion and toxicity, because it's professionally controlled and professionally applied. And because it is so high concentrated and the patient has to come to the dentist, it is applied every 3 months, 6 months, and on yearly basis, so maybe it's less frequent. Examples are acidulated phosphate fluoride gels and fluoride varnishes. As compared to the self-applied, these products are of low concentration, equal to or less than 1000 parts per million of fluoride, and self-applied can be done every day or on a weekly basis, or every 14 days, 15 days, fortnightly. Typical examples are the fluoridated toothpaste that we use, and we have some fluoridated mouthwash, mouth rinse as well. So understand the differences between these two. Now, the professionally applied topical fluoride again is broadly classified into solutions, gels, and foams, and we have varnishes, and we also have prophylactic paste. So this table basically tells you what are the fluoride agents that are available in the market for us to use, their concentration, fluoride concentration, and the product that is available. For example, we have 2% neutral sodium fluoride, which contains 1% fluoride, and that is approximately 9,200 parts per million fluoride. Okay, so similarly we have 8% acidic stannous fluoride, and we have 1.23% acidulated phosphate fluoride solutions and gels and foams. So it is available in all three kinds, and 12,300 parts per million of fluoride is available when we do topical fluoride application. Another one we have is fluoride varnish. So we have 5% fluoride varnish, which contains 22.6% fluoride and so much parts per million. The most typical that we use in our clinic, I have put Durafit here, okay, because we use it in our clinic. So you must be familiar with the product. So Durafit is what we use, and we have also Fluor Protector in the market, which contains 7,000 parts per million of fluoride available in that product. So we have different products, and topical fluoride varnish is particularly useful in young children, okay, and in localized white spot lesions and tooth sensitivity. So we will discuss this later, but for now just remember topical fluoride varnish are used in very young children. So topical fluoride can also be used in prophylactic paste. Remember, once you complete your scaling and you want to do polishing, you use prophylactic paste. So if you use prophylactic paste which contains fluoride, it kinds of replenishes the loss of enamel surface during prophylaxis. So the fluoride is replaced back. So these are the professionally applied topical fluoride we can use in your office. Now, professional topical fluoride application can be done in two ways. All right. So first one, any ways that you use, the first thing you must ensure is that there is oral prophylaxis is completed. Now this is to ensure that there is no pathological plaque, right? So if there is a thick, dense pathological plaque, the topical fluoride cannot come in contact with the enamel. So make sure the tooth is the oral prophylaxis has been completed and the tooth is free of plaque, so that the topical fluoride comes in contact with the enamel. So there are two ways to do the topical fluoride application. One is the paint on technique, and this we particularly use with solutions and with varnishes, and the other one is the tray technique, and we use this particularly when we have topical gel. Okay, so this paint on technique is very simple. You take the solution and then you simply paint the solution onto the tooth surface. Okay, very sequentially, quadrant wise, so all the smooth surfaces interproximally. You can use floss which is soaked in the solution, and you can pass the floss between the tooth to reach the interproximal areas. And there are certain techniques we will discuss when we're discussing the topical agents that we use. So for now, remember, solutions and fluoride varnish are used by paint on technique, and we have some topical gels which has to be used in these specialized disposable single-use trays, in which you fill the tray about 1/3 of the tray with fluoride gel, and then you place the tray into the mouth, and then you have this saliva ejector to control the saliva, because the patient will salivate with so much tray in the mouth, and any excess saliva that it comes. So remember, I told you fluoride varnish we apply in young children. So this is the reason why young children may find it very difficult to tolerate these trays in the mouth, right? And because it may be mouthful for them, very uncomfortable for them. So we normally use topical fluoride varnish for young children, because it is very simple. The child lies down, and then you can very quickly paint on the fluoride on the tooth surface, and this procedure becomes very easy for a very young child, especially when the child is mentally disabled or physically challenged or mentally challenged. Okay, so now we go into the specific fluoride agents that we can use. So we have 2% neutral sodium fluoride. The agents that we use, it has already been covered in your community dentistry lecture, so we are going to very quickly see the salient features only. When you apply 2% sodium fluoride solution, you have to make a 4-minute application, and you have to do it weekly for 4 weeks at these particular ages. 3, that is the time when all the primary dentition has erupted in the oral cavity. 7, this is the time when the permanent first molar erupt in the cavity. 10, this is the time when the maxillary canines erupt into the oral cavity, and 13 when the maxillary, when all the second molars erupt into the cavity. So if you see, all these are basically coinciding with the eruption of the permanent teeth and completion of dentation. So once at these ages, so when a child is 3 years of age, he has to come 4 times. Okay, so 4 weeks consecutively, every week once he has to come for a 4-minute application. So this, so the disadvantage was that there were just too many visits, and parents tend to forget that they have to go for a topical fluoride application. But this was how topical fluoride application started, uh, begun initially. So this was what it was used in the start, the first thing first, and the only advantage was patient compliance. Then when people were working with sodium fluoride, they were also working with other forms of fluoride which can have increased uptake, and concentration of fluoride can be increased on the enamel surface. So they came up with Stannous Fluoride, and this was available as a solution, but the Stannous Fluoride was unstable, so it has to be freshly prepared each time because it could not be stored, and it has to be, the suggested recommendation was it has to be applied for 2 minutes to the mouth. So same paint on technique, we ensure that the tooth is covered for 2 minutes with Stannous Fluoride solution. You can do it biannually or annually once, and the caries reduction was found to be 32%. It was quite high, but the only problem was it was unstable, it had to be freshly prepared, and it had this metallic taste, aftertaste, and it used to irritate the gingiva, and it used to cause staining on the teeth. So for these reasons, it's not very commonly used, so people are still using 2% sodium fluoride solution. With more research, we found that if the pH of the fluoride solution can be dropped and make it acidic, it kinds of improves the uptake of the fluoride. So remember from the first few slides that we discussed, etched enamel or conditioned enamel. So this was what the product that came out, 1.23% of acidulated phosphate fluoride. So basically it is sodium fluoride in which the pH has been adjusted by addition of phosphoric acid, and this is available as a solution for paint on technique, and if it is also available as a gel by adding methyl cellulose to the solution to make it a gel, and you can use it for tray technique. So when we talk about tray technique, this is what we are talking about, 1.23% acidulated phosphate fluoride, or in short called as APF gel. So the pH, if you see, the pH is 3 here and 4.5 here, so it's quite acidic. And similarly, Stannous Fluoride is also has got an acidic pH, but people have not been able to convert it into a gel formation. The caries reduction is by 28%. So remember, when I talk about caries reduction, the idea is to tell you that we cannot have 100% caries reduction because caries is so multifactorial, and these topical fluoride applications, they are a temporary measures, and therefore they have to be done over a period of time. So they have to be done frequently over a period of time. So this is not one-stop treatment. So the advantages of APF gel was that it was stable, and because the enamel gets conditioned because of the very low pH, the fluoride has deeper penetration, and there is a fluoride reservoir also, and the gel itself increases the adherence of the fluoride compound to the tooth, and it saves time because if you use the tray technique, we can use both the arches together. We can apply topical fluoride for both the arches together simultaneously. So within 4 minutes, everything is completed and done. So you can apply APF gel biannually or annually, and the application time is 1 minute to 4 minutes. So basically 1 minute is a minimum time you must keep the gel in contact with the tooth, and that is the first minute maximum fluoride uptake happens. And over a period of time, till 4 minutes, the fluoride uptake keeps on happening and keeps on reducing, and after 4 minutes there's no more fluoride uptake, so there's no point keeping the gel for more than 4 minutes. So minimum 1 minute, maximum 4 minutes. So if you have a patient who is cooperative, give it 4 minutes, and if the child is young and restless, maybe you can give it just 1 minute, it would be enough. The only advantage is because it is acidic, it has a bitter and a sour taste to it, and now it is available in different flavors. So basically it is taken care of, But the repeated and prolonged exposure may cause a loss of luster and roughening of composite restoration and porcelain restoration. So you have to be really careful when you choose the kind of fluoride that you want to use in a patient. So if you have a patient who's got a lot of composite restoration or a porcelain restoration, maybe you don't want to go in with 1.23% APF gel. Maybe you want to use sodium fluoride, neutral sodium fluoride solution for the purpose. So you need to make a clinical decision depending on the type of patients you have. So I cannot say that one product would be sufficient for everyone. So you have to make a choice. You have to be uh, vigilant what is required. Then we have the fluoride varnish. The advantage of fluoride varnish is that it's just like a nail paint. So as you apply the nail paint on your nail, it dries off and the nail paint remains on the nail. So similarly, the fluoride varnish is same. You paint it on the tooth, and because the fluoride compound is in an alcoholic solution, the alcohol evaporates and the enamel thin layer of fluoride is formed on the tooth surface, and this increases the contact time of enamel with the fluoride, because the thin layer of fluoride remains on the enamel for up to 12 hours, and therefore there's so much time the enamel has to take up the fluoride. So this was one of the advantages of fluoride varnish. And of course the other advantage is that those children, those people who cannot tolerate the tray method, you can go ahead and use this topical fluoride varnish. So topical fluoride varnish, the advantage over the solution form is that in the solution form you have to keep applying the gel or the solution for at least 4 minutes, but in varnish it can be done as quickly as in half a minute, because the varnish dries off very quickly and the layer of fluoride varnish remains on the tooth surface. So we have different products like Durafit, and it has 22,600 parts per million of fluoride. The caries reduction in permanent tooth has found to be as high as 40%, and caries reduction in deciduous teeth has been found to be up to 44%. So you see here I've given you a range 7 to 44%. So again, the disclaimer is that do not expect 100% caries reduction with any of the products. Okay, so topical fluoride is just one of the armamentarium in the prevention of dental caries. Other would be home hygiene, brushing technique, the dietary changes, and things like that. All right, so be aware of this. Then we have fluorapatite, which has 7,000 parts per million of fluoride. We need to know all this, because the next time when you go out into a dental conference and they have this trade fair going on, and the people are trying to sell you some products like for prevention of caries, what you have to do is you have to go there and see how much parts per million fluoride is there. Is it a varnish, is it a solution, and what innovative or new product the companies are offering. So before you buy anything, you must have these background in your of knowledge before you buy any product. Okay, so when you apply topical fluoride, there are some enamel reactions going on in the surface. For example, 2% sodium fluoride, when you apply, calcium fluoride is formed, and when you keep applying 2% uh, sodium fluoride over 4 minutes, there comes a level where the layer of calcium fluoride is formed and you have a choking effect. So what this choking effect basically means, that if you apply 2% sodium fluoride for more than 4 minutes, like 8 minutes, 20 minutes, you will not have any additional advantage because of this choking effect. So 4 minutes is enough for formation of calcium fluoride, and after 4 minutes you have this choking effect, so no point applying. And this calcium fluoride acts as a reservoir, and it stays in the fluoride in the plaque, and whenever there is a drop in the pH, the fluoride is released from calcium fluoride to form hydroxyapatite. So that is how it works. When you have 8% sodium, 8% stannous fluoride, tin trifluorophosphate is the compound that is formed, and from here the fluoride is released to the tooth. Similarly, when you're using APF gel, the intermediary compound is dicalcium phosphate dihydrate, and of course also calcium phosphate. So these are the products which needs to be formed so that the fluoride can be released to the enamel. So just remember, these are some important compounds related to each of the topical fluoride agents that we use. So with that, we finish the professionally applied topical fluorides, and we also have self-applied topical fluorides, and these are dentifrices and fluoride gels and fluoride rinses that can be used. So remember here, let's go step by step. So these products can contain from 500 parts per million of fluoride to up to 3,400 parts per million of fluoride. So if you see, it's the range is quite wide, and we will discuss this a little later. So let's take fluoridated dentifrices, and these are the products what we use as part of our daily personal hygiene, and you're basically brushing daily with the dentifrices. So if you use uh, fluoridated dentifrices on a daily basis, what you're doing is you are exposing the enamel to daily doses of low concentration of fluoride, and the studies have found that this is the most effective way of providing topical fluoride application for the tooth. So whenever you are advising any patient to prevention of caries, ensure that you advise fluoridated dentifrices. So these dentifrices contain up to 1000 parts per million of fluoride or 1450 parts per million of fluoride. So studies have found that anything less than 1000 parts per million or 1004 parts per million is really not effective in prevention of caries. So we here have a dilemma that most of the toothpaste which is advertised for use for kids, they have 500 parts per million of fluoride and 750 parts per million of fluoride. But technically, if you see, they are not very useful in prevention of caries. So you really have to use a fluoridated toothpaste which contains 1000 parts per million of fluoride or up to 1400 parts, 450 parts per million of fluoride. Uh, Now you will tell me the toxicity of fluoride will be high in children because the children will be swallowing the fluoride, the dentifrices, right? So what has been advised is that for children who are under 3 years of age, from the first tooth that erupts, that is about 6 months of age, till 3 years of age, you have to use a smear layer of fluoride. That is, this is as big as a grain of rice. That's it. Okay, so it has to be so small. So even if the child swallows this, there's no chances of fluoride toxicity, either acute or chronic. And when the child is crossed 3 years of age, has all the primary dentition, and it is now able to expectorate the expectorate the uh, toothpaste, then you can go ahead and use a pea-size fluoridated toothpaste, which must be a minimum 1000 to 1450. So this will prevent fluoride ingestion and fluoride toxicity. So we need to remember that after 6 years of age, any amount of fluoridated toothpaste can be used, so it really doesn't matter. So this is how you have to advise fluoridated toothpaste in children. Most of the time, the agent that we have, the fluoride agent, is sodium monofluorophosphate, which is present in the toothpaste because it goes well with the abrasive agents. So studies have found that the abrasive agents react with the fluoride and makes the fluoride unavailable for topical fluoride. So sodium monofluorophosphate adjusts very well, does not react with the abrasive agents that is used in the toothpaste. So this is fluoridated dentifrices, single most best method, because not only you are applying topical fluoride, but you're at the same moment you're also removing the pathological plaque. So it is like a two-in-one action when you are using fluoridated dentifrices. We also have fluoride gels, and fluoride gels are typically recommended for children who are at high caries risk. And when I say children with high caries risk, I'm talking about children who are more than 6 years of age and who can effectively spit out the fluoride gel, that is to avoid any toxicity. So these children can be children who have got adolescent rampant caries, and these children who are having xerostomia. These are the children who are having orthodontic braces, which makes uh, oral hygiene difficult. So they can be given the gels. You must remember these are gels. These are not toothpaste. They are not for brushing the teeth with. Okay, these are the gels for you have to apply on the tooth with your finger and let it stay for a minute, and then the child can spit it out, and you can use it daily for 4 weeks uh, till your caries risk changes to a lower level. So these are fluoride gels, Um, I have listed out GelCam, which contains 0.4% stable stannous fluoride, and then we have NutraCare, which contains neutral sodium fluoride for home use 1.1%. So a lot of products are available. You must be vigilant on what product is available and how are we going to use it. Of course, this is of very limited use if we consider that the 1/3 of fluoride is lost within the first 24 hours when you use this gel, but nevertheless it provides some degree of protection, so we must use that protection very well. And the only thing is hazard of toxicity due to danger of ingestion. So if you give a very good instruction to the patient how to use, this is less likely going to happen. So gel is another form of self-applied topical fluoride at home. The other one is Fluoride Rinses. Okay, again it is available in different concentration like I have listed out for you here. So 0.05% for daily use, 0.2% for weekly use, and 0.5% for fortnightly use. So as the concentration increases, the application duration is also increased. So depending on how the patient wants to use it, you can advise it. What I have put here is a picture of Colgate Phosphor. It is very commonly uh, advised for children who are having orthodontic treatment or adolescents who are having orthodontic treatment to protect against incipient caries, white spot lesions, because children find it very difficult to brush their teeth with. All right, so these are fluoride rinses. So we have looked at fluoridated dentifrices, fluoridated rinses, fluoridated gels. There is something called as certain lethal dose and safely tolerated dose. So make sure whatever the child is having, it is always less than the doses that have been recommended uh, with fluoride use. Okay, for adult this is the dose, and these are the signs of acute toxicity. Very less likely to happen because the amount of fluoride that the person has to ingest is quite large, and whatever fluoridated toothpaste are available, they are available in sizes that even if the child eats up the whole toothpaste, fluoride toxicity is less likely to happen. So government has regulated the amount of fluoride that can be used, and also on these fluoride containing products there is a sign that the fluoride, this is a poisonous product. So just to make sure that the person who buys the product understands that it can cause life-threatening toxicity. And when we talk about fluoride toxicity, we also have to talk about chronic fluoride toxicity. Dental fluorosis, skeletal fluorosis can happen, and these are like quite common in the factory workers which are dealing with fluoride products as part of manufacturing. So less likely to happen with topical fluoride, but nevertheless you must be aware of the fluoride toxicity. Because fluoride toxicity was there, manufacturers have come out with non-fluoride remineralizing agents, and one of them is tooth mousse. Again, I'm using tooth mousse here because this is what we have in our clinics. So you should be familiar with this product. So what this contains is casein phosphopeptide and amorphous calcium phosphate. So basically, it is a supply of calcium and phosphate ions to the tooth structure, and casein is again derived from milk, and it is got anti-carcinogenic properties. So this is a product which does not contain fluoride, and it has the ability to remineralize the demineralized enamel and can be used for prevention and maintenance for children who are at caries risk. So must remember that we also have this product. Okay, to end my session, we have this picture here which very neatly uh, shows a tug of war that is happening with the bacteria and sugar on one side and saliva on fluoride on the other side. So whichever side is more, the remineralization demineralization cycle shifts to that side. So if saliva and fluoride are more, then the remineralization will happen. If the bacteria or carcinogenic bacteria and the amount of sugar available for fermentation is more, then the demineralization will happen. So this tug of war is constantly going on in everybody's mouth, and the amount of and these factors will decide whether this person will have caries in the future or not. So with this I end the session, and this was also the last session in the uh, lecture series of preventive dentistry. and I hope you have all learned the basic foundations of preventive dentistry, uh, from infant oral health care to diet to topical fluoride, and the application of CAR and sealants in prevention of dentistry. All right. So I hope to see you in the clinics, and we will be having a Google Classroom where I'll be putting up some videos demonstrating the various topical fluoride application using the tray technique, using the paint on technique, the fluoride varnish, the solution, and we will have more assessments and quizzes there. So I'll see you in the Google Classroom. So it is bye bye from me.